We'll start. So, good afternoon, everyone. Welcome to this Society of Occupational Medicine with Institute Employment Studies and speakers from Work and Health Unit and the Bank of England Worklessness Due to Ill Health seminar webinar. I'm Nick Powell, Chief Executive of SOM. It's very interesting, topical. This is an issue in BBC News yesterday. It's number 2 on the item, and some great research is going to be presented today, as well as some solutions. And we're really pleased to have our patron, SOM patron, Dame Carol Black, to chair and take us through this afternoon. I'll be there in the background feeding questions to Carol and looking for hands, but it's a really good schedule. And so enjoy the afternoon, and do introduce yourself as well on the chat if you want. But over to you, Carol, and thanks very much.
Nick, thank you very much, and welcome to everybody. Good afternoon to our discussion, as Nick said, on worklessness due to ill health. We have an absolutely stellar team to inform and challenge us, and I hope to offer us some solutions. I'm very keen, as Nick said, that you should participate too. And to do this, please either place your questions in the chat box. Nick is going to keep a good watch on those, or use the raise hand facility in between us. We will try and make sure we see as many of those as possible. As Nick said, we could scarcely have a more topical subject to discuss: worklessness due to ill health. Of course, there are many reasons for people not to be in the workplace, but I think that we can all agree that in the past 2.5 years, worklessness due to ill health has become a crucial issue. And I would like to start off by quoting from an article by John Byrne Murdoch in the Financial Times on Friday, the 7th of October. I do hope John is in the audience and will say something a bit later on. But he said between January 2015 and January 2020, economic inactivity gradually descended in a virtual straight line as more and more people found work. Had this continued, there would today be about 8.3 million economically inactive working age Britons. Instead, we've seen this climb to 9 million, the only country in the developed world where people have continued dropping out in even greater number beyond the acute phase of the pandemic. In that article, he then offers us some causes of this reversal, and I think we would agree with most of them. As he said, a crumbling healthcare system. Both short and long-term conditions are not being treated in a timely way, whether that's replacing your hip or stabilizing an insulin-dependent diabetic. A mental health crisis. We've all seen mental health or poor mental health go up the agenda, both in workplaces and indeed in our population in general. A mix of the two compounding the issue, and then sadly an increasing number of people reporting multiple long-term conditions. The number has rocketed by 735,000 in 2 years. The longer this situation exists, the less likely we are to be able to get people into work. There's a level of physical and mental health below which work is impossible, but you don't have to be 100% fit in order to work. I said this very clearly in my 2008 review, Working for a Healthier Tomorrow. Work, if good work, can help promote recovery and rehabilitation, and it minimizes the unwanted and harmful effects of long-term sickness, absence, and worklessness. As we all know, there's a very large mental deficit associated with unemployment and physical inactivity. Occupational health professionals surely have an important part to play here, and I'm very pleased that we're going to hear from some of them later in our panel discussion. Hundreds of thousands of people economically inactive due to illness say they would like to work if they could. Indeed, more of such people than those out of work and healthy. And just to come back to John Murdoch again, he ends his article by saying these wake-up figures should be a call to government. I think our first two speakers will agree with that, and that support is very badly needed. Before I hand over to Josh, Nick, I just thought we'd put up this slide that I've unashamedly taken from John's article on Friday last, because you can see very clearly the gap. So is it possible for us to just flick that up? And there you can see the rates of chronic illness in the UK, how they shot up during the pandemic and continued to climb, and the gap between pre and post pandemic. And again, many people who are out of work saying with the right support, they would like to be back in the workplace. And he just mentions the Restart scheme, a government scheme to tackle unemployment, still got quite a lot of money in its coffers, and maybe that could be made available to those outside the labour force who have never ever before needed more support than today. So with that very brief introduction, we're going to come on to our first speaker, who is Josh Martin, who's an economic advisor at the Bank of England on secondment from ONS. So Josh, the floor is all yours. We're going to have you talk, and then I hope we'll have some questions from the floor, so to speak. So please be thinking of your questions as Josh talks to us.
Thanks very much, Carol. Could someone confirm they can see my slides?
Yeah.
Fantastic, thank you. Thanks, Carol, for that introduction. It's great to be here, and those excellent opening remarks, Carol. I agree very much with all of those. I should say before I get going that these are personal views, not those of the Bank of England or any of its committees. And I'm going to talk about long-term sickness and labour market outcomes. This is joint work with Professor Jonathan Haskell, who's an economist at Imperial College Business School and a member of the Monetary Policy Committee at the bank. So Jonathan and I got interested in this topic in respect to economic developments through and since the pandemic, and in particular some of those figures that Carol was just highlighting there, the increase in economic inactivity. Of course, these issues about employment and unemployment and inactivity are all very important for our understanding of the economy and for the making of monetary policy. So we wanted to dig into this feature of the labour market in a bit more detail and understand really what was going on. So on the labour market and these statuses, let me start out with something that I'm sure you all know. We can cut the labour market up into three sort of main statuses: people who are in employment, those who have jobs, people who are unemployed, and people who are economically inactive. To be unemployed, you of course need to not have a job, but crucially you need to fulfil a statistical definition set out by the International Labour Organization, and it is this: you must have searched for work in the past 4 weeks and be available to start in the next 2 weeks. If you don't fulfill both of those criterion, then you are economically inactive. Even within the economically inactive, though, that's quite a large and diverse group of people, some of whom do actually want a job, but they just happen not to be fulfilling those statistical criteria, some of whom don't want a job. And so on this diagram here, you can see there's various sort of layers to all of these definitions. If we're interested then in the long-term sick in the population, we might want to understand where they are across these dimensions. And if you were to look at the official labour market statistics published by the ONS, my former employer, you would find that they define the long-term sick only with respect to the economically inactive and provide this breakdown between the long-term sick who do and don't want a job. But that, of course, hides the fact that there are many long-term sick who are working or are unemployed, and some who are searching for jobs and some who are not. So in our paper, we wanted to establish some new facts about long-term sickness and their labour market outcomes. to better understand the problems and the drivers, and therefore hopefully help some people identify the solutions. Now, I should say I'm not I don't know very much about occupational medicine. I'm not a health person. I'm an economist and sort of labour market analyst. So I shall leave all the policy recommendations to someone else, but let me hopefully take you through some of the data. So we define the long-term sickness in this way, using data from the Labour Force Survey, which is a very large household survey run by the Office for National Statistics. For our purposes, long-term sick are people who answer yes to the following question: do you have any physical or mental health condition or illness lasting or expecting to last 12 months or more? And if they answer yes to that question, they're subsequently asked, does this health problem affect the kind of paid work that you might do? And if they answered yes to that as well, then we shall call them long-term sick. Of course, they might answer no to that second question, in which case they clearly still have a long-term health problem, but it's perhaps less severe. It doesn't impact the sort of work that they might do, and therefore it's slightly less relevant for our sort of analysis here. If you were to look at the official labour market statistics, as I was saying, the definition is different, and it is only, in fact, people who say that the main reason for not looking for work or being available to start work is long-term sickness or disability. So that is narrow in two ways. First, it omits anyone who is working, but long-term sick, and there are many of those. And second, it limits only to people who say that the main reason for their inactivity is long-term sickness. People could instead be retired, but have long-term sickness as a sort of secondary driver. These would be omitted from the official statistics. So we're trying to go a little bit under the surface here and hopefully shed some light.
Josh, can I just interrupt you? There are some blocks that means that we can't quite see these slides. I don't know why that's happening.
Is it on the side? Does that make things better, Nick?
It doesn't actually. No. Oh, it's gone. That's gone. It's a bit on the top as well, maybe, but that's on the side on the right. It's gone. So
okay.
Yeah, I think it could be fine as is. So let's keep going.
Okay, my apologies. Hopefully that doesn't obscure things too much. So let's have a little look at the data here then. So on this chart, we've got the number of long-term sick people in the working age population. I'm going to focus just on the working age population. Of course, there are many long-term sick people of older ages, but again, given our focus on the labour market, let's focus on the working age population, by which I mean 16 to 64-year-olds. The solid line here, which corresponds to the axis on the left, is the number in millions of working age long-term sick people in the population. And that's risen from about 5 million in the late 90s to about 7 million today. The dashed line corresponds to the axis on the right-hand side, and that is the proportion of the total population, the total working age population, that those long-term sick people make up. And that's increased from about 14% in the late 90s to about 17% today. So this is a very large group, and it's an increasing group over time. The increase, however, has not been continuous through this period. I've drawn a few fairly crude trend lines on here for different periods, nothing very scientific here, but you can see that during the pandemic, the increase was much more rapid than any period in the past. There are a few sort of humps in the middle of the time series, but those are caused by methodological changes. You can look through those, but the trends were fairly modest before the pandemic, but much more rapid since the onset. How does that vary by age group? So this chart breaks down that dashed line from before into 3 different age groups. The blue dashed line is the same line as on the previous chart. The green line now is for people aged 50 to 64, the red line for age 25 to 49, and the orange line for workers aged 16 to 24. And you can see that before the pandemic, a lot of the growth in the long-term sick population was driven by younger people aged 16 to 24. The orange line was sloping up just before the pandemic. But during the pandemic, the increase has been driven pretty much across the 3 age groups fairly equally. So this does seem to be quite a widespread issue through the pandemic. Another fact that's very interesting, quite striking, a little sobering, is that the unemployment rate for the long-term sick is persistently higher than for the non-sick. So recall that these are people who meet that statistical criterion, that are looking for and available to start work but don't have a job. and it's approximately twice that of the non-sick, and is consistently so over the last 20 years or more. It also takes a little longer for the long-term sick to, for the unemployment rate of the long-term sick to return down to normal after the financial crisis, whereas for the non-sick it returns sooner. So perhaps this group is more susceptible to sort of economic turmoil than the non-sick are. That said, the inactive long-term sick do have a higher propensity to want a job. These people are not unemployed, therefore they don't meet the criteria. They may not be searching, they cannot be searching and available, or else they would be unemployed. But they are inactive, but they do want a job at a higher rate than the non-sick. So there's clearly demand for these people to work. There's a higher unemployment rate and a higher rate of wanting a job, and yet a lower rate of employment. So there seems to be some sort of structural or cultural or systemic barriers here, which I'm sure others in this event will be able to comment on. So just to summarize then some facts on the long-term sick in the labour market, there are many of them. The group is large and rising. About 50% of the long-term sick work, which means that they account for about 10% of the workforce. So this is not a trivial group. The participation rate is lower, but the unemployment rate, the unemployment rate is higher, and the inactive are more likely to want a job, as I've shown you. Just to skip to the last bullet here, the long-term sick are more likely to work part-time if they work at all. And even after controlling for this working pattern, they work fewer hours per week on average than the non-sick. So that has some implications for labour supply for the economy. Let me turn now to the more recent period and the pandemic. This chart on the right-hand side here shows us changes in the rate of economic inactivity by age group between 2019 and the latest period for the UK and a bunch of other countries, developed countries, the G7 countries and some country aggregates. The latest period is the second quarter of 2022 for the UK and most of the other countries, and the first quarter of 2022 for some of them. The gold bar, which for the UK points out to the right, tells us that the inactivity rate for the UK increased over this period by 0.7 percentage points, whereas in most of the other countries it decreased. And this is to the point that Carol was making earlier on, quoting John Byrne-Murdoch, that the UK is very unusual in this regard across developed countries in having an increase in inactivity since before the pandemic. The bars below the gold bar then, the purpley one, the orange one, and the teal sort of turquoise coloured one, break that same change out into the different age groups. And you can see that for the UK, there's an increase in the youngest age group. Well, there's an increase in all three age groups, but there's a particularly large increase for the youngest age group and the oldest age group. And again, that's quite in contrast to all the other countries, particularly for the older workers, where the UK is pretty much the only country to see that increase.
So the kettle's spoiling.
Oh, I'll get it.
That's not to say that the UK doesn't have a low level of inactivity. Historically, the UK labour market does have a very high participation rate, a low inactivity rate. So the level is not much of a problem, but it's the change in the latest period that has caused some concern. And this is that chart that Carol was quoting from the Financial Times, which does show very strikingly that the UK is pretty much the only developed country that has deviated from trend and not returned to trend. All countries did deviate from trend during the pandemic, but have since returned to trend or are returning to trend, whereas the UK is quite the outlier in this regard. We've got our friends from the Institute for Employment Studies here at the event as well. So let me show this excellent chart from their September labour market briefing, which shows the increase in economic inactivity since just before the pandemic, which is the line through here, and then the proximate reasons for that increase. These are reasons based on the main reason for inactivity. And as I was telling you earlier, that main reason does perhaps hide something under the surface, but it's nonetheless instructive. The dark blue line at the end here shows us the increase that's due to long-term sickness, which is a good fraction of this total. The increase due to retirement, which has long been touted as an important factor. The Great Resignation has been quoted, but is not that great in this chart. An increase in students is also a big contributor. So there's a clear driver of this increase in inactivity in long-term sickness, and as I showed you before, an increase in long-term sickness in the population as a whole. Drilling in then to the older age group, and this is a chart from the Health Foundation, who put out a very nice report on this just a few days ago. They drill into to people aged 50 to 69, where we saw a big increase in inactivity in the UK since before the pandemic. And again, they look at the different reasons. They factor in the secondary reasons as well as the primary reasons. And the increase since before the pandemic, they find, is driven mostly by long-term sickness, which is the red bar. Reasons other than long-term sickness and retirement also contribute some, and retirement without ill health, which is the darker blue bar at the bottom, is not contributing anything at all to the increase. So the Health Foundation agree that long-term sickness is the main driver of the increase in activity in older workers, and as we saw a moment ago, also in the population as a whole. So clearly there's some very important trends going on here. A big increase in activity driven by long-term sickness. Long-term sickness has increased across the age groups in the population, but it seems to be particularly driving older workers out of work. The UK appears to be unlike other developed economies, suggesting some sort of UK specific factor. I'll speculate on what that is in a moment. And this cannot all be explained by long COVID. I haven't shown you any data on this, it is in the paper, but we and others estimate that the number who've left work because of long COVID is about 100,000. There are many more people who report ongoing symptoms of COVID, but not all of those would have left the labour market, and some will not have been in the labour market to start with. But we put the exits due to long COVID at about 100,000, and yet there are more than 500,000 out of work since before the pandemic. So long COVID alone cannot explain all of this increase. And finally, the last topic I'd like to touch on is a little bit to the future. So the pandemic, although it has been very difficult in many respects, one perhaps silver lining of all of that was the work from home revolution, an increase in people working from home, a change in the social norms that made that easier, and a change in technology as well. You might think, you might hope that an increased prevalence of home working would enable people who are long-term sick, people who are disabled, to better participate in the labour market, if it might break down some barriers to that participation. And if that were the case, we might expect to see a closing of the employment gap between the long-term sick and the non-sick. These two charts tell us otherwise. The chart on the left is the flow rate from unemployment to employment in any given quarter. So the proportion of people who are unemployed in the first quarter and whether or not they get a job in the second quarter. The dashed line is the single quarter data. The solid line is a 4-quarter moving average because it's a little bit noisy, but they don't converge over the last year. In fact, if anything, they actually widen a little. And likewise, the chart on the right-hand side, which shows us participation rates for the non-sick and the long-term sick. And again, they don't close since the pandemic. In fact, if anything, the gap widens. So it does not look like the work from home revolution is helping in this regard. Why might that be? Well, this is a sneak preview of some new work from an update of our paper, where we look at the sorts of jobs that the long-term sick hold in the labour market if they are working. Remember, many long-term sick people do work. So if they do work, what sorts of jobs do they do? What sort of industries are they in, and what sort of occupations do they hold? These bars show us the ratio of the employment share of the long-term sick compared to the non-sick. That's a bit of a mouthful, so let me explain what that means. Let's presume, let's pretend that 10% of non-sick workers work in manufacturing, but only 5% of long-term sick workers work in manufacturing. Then the ratio is 10% to 5%, or half the number, half the proportion of the long-term sick relative to the non-sick work in manufacturing. So they are underrepresented in manufacturing relative to the non-sick. So that's what this chart, these two charts are showing. The bars in red, pointing to the left, are where the long-term sick are underrepresented, and the green bars pointing to the right are where they are overrepresented, and the blue bars in the middle are where the employment shares are fairly similar. And we can see that the green bars, the bars at the top, the long-term sick are overrepresented in typically lower paid, lower skilled industries and occupations, and underrepresented in typically higher paid, higher skilled, more professional type occupations and industries. That's important for the labour market outcomes of the long-term sick population, but it also helps to explain why home working doesn't work for them. This chart takes that same ratio and compares it against the proportion of people in a given occupation who might work from home, and it finds that there's a negative relationship. That is, the sorts of occupations that the long-term sick are more likely to do are not the sorts of occupations that allow for home working. We've got a little bit more to do on all of this analysis, but I think it does help to demonstrate that work from home is great for those for whom it works, but it's not the silver bullet for the long-term sick population. Just in my last minute or so, looking to the future, what we see is a population and a labour market with many more long-term sick people, which definitely requires us to sit up and take notice. There's a sort of concurrent change in preferences, I think, towards people being less inclined to work in some cases, or at least working fewer hours. I talked about a great resignation. I think it's a great reevaluation. So perhaps there's a change in preferences as well. There's definitely impacts on productivity from all of this that we need to be mindful of. And work from home, unfortunately, will not resolve this, at least given the current skill mix and the job distributions of the population. So I see some implications, but I'm sure others in the event will have much more to say about this than I do. There are implications for measurement, which perhaps is just for the labour market nerds like myself, so I shall pass on that for the moment. But for policy, I see two potential implications. We've got a long-term sick population that is growing who clearly want jobs, but have less success in getting them. That suggests to me some sort of structural or cultural barriers that perhaps can be broken down. And secondly, if home working isn't going to close this employment gap, given the current skill mix or job mix, maybe that suggests the need for a change in that job mix, maybe through training or maybe through a change in attitudes of employers, however that could be achieved. And let me stop there. Thanks very much.
Josh, thank you very much. Nick, are there any questions in the chat that we can...
Well, I'm particularly keen to hear from David Buck from King's Fund, who has to leave at 3, and also we've got someone from IPPR. So having think tanks here of that caliber is always good to hear their views, but particularly from David Buck, because I know you're short on time.
Can we start with David then?
Hi, hello. Nice
David,
to see you.
hello.
And thanks very much, Josh. That was really fascinating. So I've got lots of thoughts and questions, some of which are probably idiotic, and this might be one of them. But I guess we've known for a long time about the impact, and obviously Carol Black is the exemplar of this, about the impact of multiple long-term conditions on health and inactivity. I guess one thing when I was thinking, I don't think it explains the trend that you've been sharing, Josh, particularly, but I guess there's something about what we haven't talked about is ethnicity and relationships to health and relationships to work. And what we do know that changes as well as sort of like age. We've talked about age distribution. So I'm just wondering whether you're looking at or think about looking at, or that you have enough data to look at, to what extent does sort of like changing compositions of ethnicity have on this, and that could affect all sorts of variables in here, or is that basically a red herring? So it's just an open question. And the second point, as you're thinking about that, I guess there was some really interesting work, again, I think it's from DWP Statistics, around no, actually, I'll leave it there. I'll leave it there. One question. Thanks very much. Sorry about that.
Josh, do you want to come back on that?
Let me say briefly on ethnicity. So David, thanks for the suggestion. It's not something we've looked at. The labour force survey would allow us to look at that. It does have data on ethnicity, but it's not a breakdown that we've considered. But I shall certainly take a look at it, and if there's anything interesting to say there, then I'm sure it'll feature in a new version of our paper. Thanks.
Good.
There's a chat question from Tom Addison. I don't know if you want to come off mute and say it, Tom, or you can put to me directly. I think I could read it out.
Entirely up to you, Nick, I suppose.
Well, you go for it.
Is that okay?
Yeah.
My name's Tom Addison. I'm from the Physiological Society. We are doing a piece of work currently about, oh, put my video on. We're doing a piece of work about the impact of ill health on older workers. And so my question, I put two questions in there. The first one was about the kind of short-term impact of ill health on the current older workers. And by that, we're sort of talking 50 to 64, looking at, you know, if these people are maybe reducing their hours or retiring earlier as a result or in part due to ill health, you know, is the Bank of England doing anything to look at what impact that will have on their finances at an individual level, but also at a productivity level, I guess, kind of macro. And the second thing was your data point around the fact that a lot, I think I understood it right, a larger proportion of people aged 25 to 49 are in poor health, but that's not currently affecting their economic activity. I suppose for our members, you know, we would say that, you know, a lot of our members are focused on kind of prevention and maintaining health. So I guess it's a kind of, is there a sort of time bomb of people who are, you know, not quite at full fitness, but they're sort of muddling through and they're able to muddle through, but as they get older, their ability to do that is less so. So I suppose selfishly, I've done two questions there, but thank you very much. I'd be keen to get your thoughts.
Thank you, Tom. Very excellent questions. Let me just reiterate this, these are all personal views and not those of the Bank of England. So a question, are we looking, is the bank looking at sort of the finances of these sorts of people who are out of the labour market? There's been a lot of speculation that the cost of living squeeze might incentivise people back into the labour market. I think we've seen an increase in the number of people over 65 return to the labour market, but of the 50 to 64-year-olds, which was the main age group in my chart, that does not seem to be the case, at least not yet. So I'm sure there's more to dig under the surface there, but I believe that the 50 to 64 and 65 and over age groups is quite a heterogeneous and diverse group of people. So I think it's difficult to do anything too broad brush on all of that. You correctly interpreted my charts that the sort of prime aged workers, 25 to 49 or something, they've got a large increase in long-term sickness, but not a large increase in inactivity. So that would suggest that there's been an increase in working ill health in those age groups, whereas for the older age groups, there's still been an increase in ill health, but it's motivated them to leave the labour market. And you characterise that as a time bomb, and I think that's perfectly a reasonable characterisation, that these people are still working, they're continuing in their jobs, perhaps they've got no choice. That could stack up more problems for the future. And briefly on productivity, of course, productivity is the relationship between outputs and inputs. If people are working fewer hours, either because they're leaving the labour market or they're staying in the labour market but working less hours, that reduces the inputs. So it doesn't necessarily reduce output. It doesn't necessarily reduce productivity, but it's certainly going to make it more difficult for firms to find the workers that they need. And we've heard about this labour shortage. So I think this is a material issue for our understanding of the tightness of the labour market, wage pressures, and economic growth, frankly.
So I might just cut in. In terms of the chat, Carol, there's a question, I think we're going to run out of time, but Annie Irving from King's College talking about measurement. Someone from Reed, so Sarah Welfare, talking about.
Can we take one more, Nick?
Yeah, well, I just, in terms of interest, I'm piqued to hear what Carsten Jung from IPPR is going to say. So maybe we can take Carsten.
Carsten, off you go.
Wow, thanks. What a privilege. Yeah, this is really great work. Thank you. And we're also doing work on the connection between health and the economy and what can be done in terms of policy. I just have one question. I thought your chart on the occupations and industry differentials in terms of the long-term sick is really interesting. I think it's really worth digging more into that, because partly it's, of course, has implications for what employers can do to make the workplace perhaps better suited for the long-term sick. So I think it's interesting from a policy perspective. But I also had a question, which is, I think you're showing stocks here in terms of over and underrepresentation. I was curious if you could also say something about changes to those stocks as a result of the pandemic. Do they look similar in terms of what the highest and lowest were, or is that quite different? Thank you.
Thanks, Carsten. Very good question. And you're right, the chart was showing stocks. It was the levels in 2019, so just before the pandemic. Some of these proportions are quite small. So, when you start dividing one by the other with sample sizes, they can get a little noisy, which is why we stuck to the pre-pandemic level. But you're right, there might be one set of relationships in the stock and a different set of relationship in the flows. We haven't looked at that, but I should take that away. That's a good suggestion. Thank you.
Thank you, Josh. I think we should move on now, because we want to try and keep up to time. And I'm sorry for those whose questions we haven't been able to address, but we'll move on, if we may, to Stephen Bevan, who's head of HR Research and Development at IES. Stephen has done a vast amount of work in this area. I'm not going to waste time reading it all out, but I'm going to hand over straight away to Stephen to talk to us from his perspective.
Thank you, Carol, and thanks to Nick and colleagues at Society of Occupational Medicine for helping to organise this event. So the Institute for Employment Studies has been around for 50 years, so we've been looking at policies to do with labour market participation and helping to promote evidence-based workplace practices in the management of people for quite a long time. I lead the work that we do on workforce health, which means we get involved in a whole range of evaluations for organisations like the DWP. So we evaluate the Fit for Work service, the Fit Note. Most recently, we've been leading the evaluation of the health-led trials, essentially the world's largest individual placement and support trial, looking at helping people with depression and anxiety back into work, with almost 10,000 participants. And we also support employers' programs and evaluating what they're doing in terms of health promotion and so on. And we also do a lot of work, have done a lot of work over the last couple of years tracking well-being during the pandemic. I'm not a clinician. I have an organisational psychology background, but I suppose I have the advantage of having worked across both policy and employer domains, and also very pleased to be a co-investigator at the MRC versus Arthritis Centre for Musculoskeletal Health and Work, which does some really high quality work looking at workability amongst people with musculoskeletal conditions. So there's a lot of really good science informing this debate. Next slide, Nick, please. So these are the four things I'm going to try and cram into my presentation. Just following on from Josh's brilliant presentation, I want to sort of focus on, I want to personalise this a little bit. So I'm going to start off with 3 vignettes, which will just remind us about the type of people we're talking about here. Then I want to talk about the clinical and non-clinical determinants of inactivity, and this is informed speculation really about why we're seeing such high levels and significant growth in sickness-related inactivity. And then I want to focus on a couple of sort of, well, I suppose tactical but really important points about where the expertise lies to deal with these problems, and are we making the best use of them? And I definitely include occupational health professionals within all that. And then finally, a sort of call to arms around how do we go about harnessing the best research to inform both policy and practice. So let's go to the first slide. So as I said, I'm trying to try and personalize this with some events to illustrate some vignettes to illustrate what we're talking about here. And I will refer to some of these cases a bit later on as well. But here we've got Jean, she's 57, got severe osteoarthritis of the hip. She's been on an NHS waiting list, waiting for surgery for 2 years. She has severe chronic pain and occasional bouts of depression. She's taken advantage of pension freedom, so she's got 25% of her pension pot tax-free, which actually affected her attitude to work and was the financial imperative to work. Although once she gets to operation, she's hoping to come back into the workforce. So she's a premature leaver of the labour market. She may be tempted back. She wants to work, but she may be lost to the labour market unless we can get employment support services to her. Because she's not claiming benefits, she's probably a bit more difficult to track. And it's hard to know what proportion of the inactive share her characteristics, but it's certainly a group that we need to be looking at. Second vignette, Nick, please. This is Richard, who's a 42-year-old general labourer. He's got more complex problems, history of alcohol problems and anxiety. He's had periods of homelessness and unemployment. He's moved back in with his mum, rent-free, so he's financially disadvantaged. He's receiving treatment. Claims he wants to go back to work in construction, although his mother's not so sure. And he's on benefit, but he's struggling to keep up with the regime of universal credit. So he's complex needs. He's a candidate for supported employment interventions potentially, but he may need intensive long-term personalised support. Next slide. So this is Jackie. She's 35, works in local government, diagnosis of multiple sclerosis 5 years ago, coping well with treatment initially. But now experiencing fluctuating and sometimes distressing symptoms. She feels a real burden to her colleagues, and she's exhausted the patience of her bosses. She's planning to give up work completely in a few months' time, possibly to do some volunteering when her health allows. Now, she's one of the people who is at work but struggling. She's got both medical and non-medical factors, which means she is a job retention risk. There are questions about whether or not employer could do more around work modification, job crafting, and so on. She's, again, representative of a group of people who may add to our list of inactive people unless we do something sharpish to help support her. Now, these are all made up vignettes, and it's easy to compile another dozen of them that reflect the range of clinical and non-clinical challenges that face different groups in the working age population. So, but drawing on Josh's really good analysis of the data and some really great contributions from the already thrice mentioned John Bird Murdoch and my colleague Tony Wilson at IES, we are, I think, getting closer to understanding the range and complexity of the causes of this big rise in inactivity that's attributable to long-term sickness. So I'm going to, I've gone for 5. And I'm going to take you through each of the 5 to look in a bit more detail. I mean, I've done this in the full understanding that there are many other factors at work. I certainly would resist the temptation to add rankings or weightings to each of these 5. They're certainly different in magnitude from each other, but they also almost certainly overlap. So this, again, is a bit of informed speculation. But let's look at NHS waiting times as the first one. We've had some more news today about the rise in the number of people waiting for surgery, up to 7 million now. I understand about 1 in 5 of the over 50s who've left the labour market say they're on an NHS waiting list. So obviously it's playing a part for a significant proportion of people. We've seen through one of our vignettes about people with osteoarthritis related hip and knee replacements. My calculations from the National Joint Registry suggest about 1/3 of all patients who are having hip and knee replacements are of working age. So that's still very significant. But we've also got challenges around waiting times for physiotherapy. Self-referral options for physio are very patchy around the country. We've still got quite long waiting times for cognitive behavioural therapy and other psychological therapies for people with mental health problems. We've got issues here with people living with intense and chronic pain, and which can really undermine workability and their psychological resilience. And it's also hard for employers to make effective adjustments, particularly if people are in such extreme pain that their functional capacity is really severely impaired. And obviously that has an effect on their mental health as well. Now, it's very welcome that we've had a new service announced on Monday to put more employment advisors in IAP services and some funding behind that. And we'll wait and see how effective that is, but that should have an effect of hopefully reducing waiting times for people to get employment-related psychological support. And I wonder whether or not we need to think a bit more about how we provide return to work advice for people who are coming off these waiting lists after treatment, but are part of this group. The danger is that their core part of their clinical problems may be resolved, perhaps not all of them, but they may they may be people who could be persuaded to come back to work, particularly thinking about Josh's figure of 50% who are, actively keen to work. So I wondered whether we need to be thinking about how we manage return to work conversations for people who eventually get their treatment. Next slide. Long COVID, very contested area. I think the data is suggesting that this is growing, about 2.3 million people living with long COVID. The latest data is, I think, that 46% have symptoms lasting over a year and 22% for more than 2 years. Just over 1 in 5 are unable to work. And 45% have had to reduce their hours. So it's not just about inactivity, it's about underemployment as well for people with chronic health conditions. And it may be part of the sort of pathway to inactivity of people having to reduce their hours in order to cope with their ill health. For some of those, that might be an early warning that they're planning or conceding that they may not be working for much longer. I think Josh's data suggests that this figure of 20% of those inactive may be an overestimate. But again, this sort of, in a sense, gives a hint about how complex and contested some of these data are. Long COVID does have many symptoms that are experienced in different ways by each individual, which also makes it tricky. I think it's clear that some of the diagnostic criteria that we're using are still emerging, and also the impact of long COVID on workability is still being assessed. I know there's some brilliant work going on. I think the UK is leading in many of these areas. We just need to make sure that some of those insights from the research are embedded in policy and practice as soon as possible. It also makes life difficult for employers. If you are interested as an employer in helping people with long COVID to stay in or return to work, I think some of the protocols for doing that, particularly given the vast array of different symptoms that people have, we still need to do some work. And I suppose the problem is that we may have a latent issue here that we're going to see even as serious rates of COVID decline. We're going to have many more people of working age who continue to be affected by this for several years to come. I do want to give a shout out to the Society of Occupational Medicine guidance material on this, which is really good quality and certainly should be referred to by many. Next slide. Not sure about how significant this is, but it does seem for some people that their financial position makes a difference. Of course, we've heard already that only the minority of those people who are inactive are on benefits. And there are, amongst some mainly professional groups, some issues around early retirement because of pension issues, particularly amongst GPs, some higher education staff, where there's a disincentive to work. And we know, and as we've seen in one of the vignettes, other older workers are taking advantage of pensions freedoms, which may cushion their fall out of work, particularly if they've got complex problems. I guess there is an issue here about the financial status of people in this group, because it does seem to me that we need to understand whether or not they are eventually going to become more financially compromised as they spend longer time out of work. And I think this is an area where we need more assessment of the role that household finances play in decisions to leave work. Next one is complexity and comorbidity, Nick. So I think John Bernard Murdoch's data suggests about just over 735,000 of the inactive have more than one health condition. It suggests to me that we need to avoid easy diagnostic silos. People who have chronic low back pain also have depression. Certainly 20% or so of them do. And so I know we need to use diagnostic clarity when we're presenting data. But in the real world, many people are facing multiple problems. And I think this causes a challenge for our efforts to retain people in the labour market and help them return to work, because it needs a much more tailored and personalised approach to managing their conditions. And it's not just the case that you develop chronic pain and then you become depressed. There are all sorts of ways that comorbidities manifest themselves, and it's a bi-directional relationship between physical and mental health, for example. For employers, it can be really difficult to modify work, redesign jobs, help assess whether or not the working environment is exacerbating existing health problems and so on. And we also know that fluctuating health conditions are really tricky for both individuals and employers to deal with, because some people, particularly with conditions like rheumatoid arthritis or MS, wake up in the morning and really don't know how they're going to feel, and they could have felt brilliantly yesterday but feel terrible today, and that makes their life pretty difficult for them clinically, but also for the employer in terms of coming up with tailored support. And there's also a bit of a risk of over medicalising some conditions. I don't mean that pejoratively, but we need to recognise that that people are living with a whole range of both clinical and societal or other issues. And Richard, the labourer, for example, only some of his issues are strictly clinical. He suffered from periods of homelessness and so on. I think that's where interventions like supported employment or an IPS and so on may be helpful to people to overcome their wider barriers to employment, which will include clinical barriers, but not exclusively. Next slide. One of the things I'm most interested in is the sort of employer role in all this, because we're sort of ironically seeing quite a big increase in the number of employers who are really interested in this area, are recognising that, of course, there's a business case for them to do more to support the health and well-being of their workforce, but also a moral case. I understand the Secretary of State for Work and Pensions are giving a speech this afternoon, imploring employers to do more. We'll see what the detail of that is. But of course, we know that there's very variable competence, confidence, resources, motivation amongst many employers to offer flexibility, modified work, accommodations, but also helping the individual to play an active part in managing their care and their return to work. I spoke to a very senior manager in a large organisation earlier in the year who said that he thought that stress is still a better driver of performance than any wellbeing programme. Now, while we've got people who share that view, we're going to struggle to get very senior managers in lots of organisations to embrace this. I hope that he was an exception, and I think he's still in the minority, but we still have a bit of an attitudinal journey to go through. Some organisations prefer to use experts like occupational physicians and nurses to help optimise attendance and manage absence, but that's only part of the vast array of expertise that's available to them through occupational health people. And I do worry that some employers, because of the way they commission external services or use even internal resources, might miss out on really helpful tools like risk assessment and prevention interventions. And I think we need to really get them to be better, more critical and informed consumers of the expertise they have available to them. We also know that complex and progressive cases can be really frightening or frustrating for some employers. And we've all seen employers who, hopefully in the minority, still prefer to offer statutory minimum support and then move to dismissal or severance or ill health retirement before probably exhausting all the options open to them. And then I think a big question is how able are we to satisfy the increased appetite amongst employers for wellbeing interventions with enough evidence-based support? My real worry is that if only 10% of the demand for increased interventions by employers is being met by evidence-based solutions, while employers being bombarded by a whole range of different services by commercial providers, asking whether or not they make any difference or not is sometimes low down the list of questions that they get asked. And I do worry that we're wasting a lot of goodwill and enthusiasm and genuine interest amongst employers for wellbeing solutions, but they're being tempted to buy things which actually have almost no evidence base for them, and those non-evidence-based interventions are crowding out the evidence-based ones. So as we get under the skin of the data and improve our understanding of the inactivity challenge, my next question focuses on the kind of expertise we have available to apply to this problem and whether we can do better. Let's look at the next slide, please, Nick. So we've got a whole bunch of experts in supported employment, disability management, case management, and they're really good at, if they're given the freedom to do so, at producing personalised, tailored, sustained support for people who are dealing with multiple barriers to returning to work. And I think we need to be investing more in them. And now I think already we've seen some really positive findings from various trials of some of these interventions, particularly individual placement and support and related approaches. I think that the technology that we have available to help them put together services and deliver good results for people, particularly people with complex needs, is something we really need to be focusing on. We have great expertise in the UK, which I believe is underutilised in terms of vocational rehabilitation specialists. And I think that we should be using the fact that they have a very strong biopsychosocial focus, so not just focusing on the medical model of how we look at this, but people's social environment, the support they have, and particularly as a multidisciplinary area of specialism, using OTs and physios and psychologists and occupational health professionals and so on. It's an underutilised discipline, and we need to find ways of helping, getting them to help people both in employment settings, but also those who are out of work and need support to get back in. Occupational health professionals are, of course, brilliant, he says grovellingly. And of course, they're employed in a range of settings. They have a variety of specialisms. Don't forget OH nurses, who perform a sterling job and are perhaps again undervalued. And they have a great understanding of the work and health interface, the impact of job demands and risk exposure and so on. There's a whole clutch of expertise that I still believe is systematically underutilised by employers. And we need to find ways of getting that to work more effectively. I know that Nick and his colleagues and also colleagues at the faculty have been really pushing hard to make sure that the profile and the role of occupational physicians can be better recognised and their contribution recognised. Now, the contributions of all these experts support people out of work through illness or injury, those in work but struggling. We've seen already our IMS vignette earlier on, those in work who are exposed to risk, those in work who need return to work support after illness or injury. But I suppose my question is, are we really commissioning these experts to deploy their skills at the right time for the right groups and in the most advantageous way? So, for example, we have a big challenge with general practice at the moment. There have been several attempts, none of them particularly successful, in helping to get occupational health advice and expertise to GPs who have always had this challenge about whether or not their role as patient advocate prevents them from providing advice about return to work, because they fear that, for many patients, that's something that they are anxious about, and they rely on their GP to give them advice and not to be the advocate of the employer, for example. So what can we do to make sure that occupational health advice is more accessible in general practice? It's just one of the challenges we should think about. It seems to me that there's a big issue for both the NHS and for the Department of Work and Pensions to make sure that they're able to marshal and access the resources available to the expertise for all these groups: supported employment, vocational rehab and occupational health. And we also need to help more employers to access the guidance of support of these expert groups. And for me, one of the challenges is to make sure that we're both deepening the expertise in this area. And I'm pretty confident we've got a very vibrant community of research in the UK. So I'm not concerned about that. I think that we've got a load of really great research coming through the pipeline. I think the other challenge is to support the deployment of this expertise across settings. So we know, for example, that supported employment interventions can help people who are in work but struggling. Part of our Health Edge Trials IPS intervention had a subgroup of our sample who were in work but struggling. Now, that's a really interesting way of thinking about how IPS can work. It's not just about helping people who are unemployed, but similarly, occupational health and VR specialists can help people who are out of work, and to do so in partnership across disciplines and across government agencies and so on, I think is one of the ways that we can make sure this expertise is taken advantage of by a wider group of people. Last slide, Nick. Thank you. So the challenge is not so much doing research. Of course, as a researcher, I'm always keen for there to be more research commissioned, but how do we make the best use of it? I think one of the things we need to think about is understanding the limits of this biomedical model. I think it's pretty clear that things like symptom severity are generally a poor predictor of work outcomes. or not as strong a predictor as we like to think they are. And also symptom-based treatment aren't usually enough to return someone to work successfully after long-term sickness. So we need to think a little bit out of the box about the limits of the clinical model. I've been taken recently by two things that I've seen. It was pointed out to me by my friend Max Henderson, work that he and Ira Madan and others have done, looking at developing a tool to look at non-illness predictors of sickness absence, which looks really, really promising. I was at the International Forum for Disability Management last week in Brussels and heard a really great study from the Netherlands, which had looked at a measure of return to work self-efficacy, where that seemed to predict very accurately both the speed at which people may return to work and also the number of relapses they have. And the greater levels of self-efficacy people have, the better their outcomes are. So I think there's a flow of really good research which is saying this isn't just about people's clinical diagnosis, it's about how they feel, their psychological state, their health beliefs, their health expectations. And we need to broaden our understanding of this, particularly looking at people with long-term illness, because it's a complex picture and you can't just boil it down to a single or even one or two diagnoses. That leads on to the next point about comorbidity and fluctuating conditions. Again, there's an argument that we need better targeted and more personalised support. You can't just say that if someone scores a particular score on the International Classification of Functioning, there's a direct read across to the type of interventions they need. It ain't that simple. We all know that on this call, but some people in government don't. And I think that we need to help them understand the subtlety of this and the complexity and the need for greater personalisation. Long COVID, I suppose, is just ought to be on any of these lists because it's something that we're still finding out about and we need to learn more about. Hopefully it won't get worse, but we have to expect that for certain groups of people, their vulnerability might still be high and the impact on their ability to remain in or return to work may be compromised. And so we need an active agenda of research in this area. We need more evidence-based workplace interventions. Paul Litchfield is very fond of saying, and I quote him almost every week, that there are too much fruit and Pilates interventions that are being used by employers. I know that won't be the only thing he's remembered for, but it's quite noteworthy and eye-catching. And we therefore need employers to be more informed consumers. Many of them want to do more, but they must go beyond just bland health promotion. And we need them to think about much more about early intervention, prevention, risk assessment. And then finally, we need a modern public employment service where evidence crowds out dogma. This is one of the areas which is very polarizing. Lots of people have got views about why people are out of work and what will encourage them or incentivize them to go back to work. Part of the IES role here is to sort of promote debate. And next month, we'll be launching a new commission looking at what a new modern employment service will look like. And we'll be looking at some of the longer term structural issues around improving access to employment support, working better with employers, how we join up public services. And we'll be kicking off with a review of where we are now and a call for evidence. And the aim is to report on this by the next election. Or that may be a bit of a crapshoot with the devil to think about when that might be, nonetheless. So that's my very quick summary of where I think we stand. IES, of course, stands ready to continue to make a contribution to this area together with our many partners. But thank you very much for your attention, and I'm very happy to join in with the debate and discussion that follows. Thank you.
Thank you very much indeed, Stephen. I'm happy to take two questions before we move on to the panel discussion. And it might be helpful if you join the panel, because I know that we don't have Tony with us, so that if you wouldn't mind. Nick, any obviously important sort of questions that we ought to pick out immediately?
I think we could open up. I mean, we've got comments from David Brown and Annie Irvine. I don't know if you want to come off mute. It's great to see Ira Madan here as well, who's as academic dean of the FOM, but obviously you've got Steve Nimmo coming up too.
Annie, would you like to come in, for example?
Oh, thank you. I just want to say, couldn't agree more with all of Stephen's analysis. I was scribbling down during Josh's presentation all the reasons I thought could explain the increase in on economic inactivity, and then Stephen's just covered all of them in great depth. But yeah, it's just that the thing of context and the non-clinical factors that shape the way people make sense of their health condition, how they perceive their capabilities in relation to the changing social and economic environment around them. And I think, you know, that's where the solutions lie, and that's where understanding and investment needs to be placed, as you know, as well as clinical input. But as we know, as you've always said, people can manage and work with health conditions, so it's about making sure that the support around that is in place. And I'd love to get involved in the new IES commission. I've been doing some work on employability, third sector, non-statutory services, and the role of personalisation there. But yeah, thanks, really great to hear, and I'll probably be watching back just to digest it all again.
Thank you. One other comment or question, anyone like? We've got David.
A few years.
David, we're having a great problem. Your bandwidth.
Yeah, your bandwidth, David. You need to
career on the.
David, I think we're not really picking you up very well. I think we'll probably move on for the moment. I think he was having a great deal of trouble, Nick. So we're then going to come to the discussion period, and we've got some people to help start us off, which is really, really important. And can we start with Steve? Steve Nimno, I'm sure, Steve, you're going to talk to us with an occupational health hat on.
I hope Steve is there. He's got broadband issues.
Well, if not, we will move on to
yes.
Steve, are you there? I don't.
Yeah, I think he's got problem. You could also, obviously, there's Jennifer Hyam from DWP. It'd be really interesting to get the government perspective.
Oh, Jennifer, why don't we start with you, and can I ask you to talk to us about what government is going to be doing? We've heard all the problems, all the challenges, the possible causes, some of the possible solutions from Stephen. Perhaps you'd be kind enough to fill us in on what DWP or wider government is doing.
Thank you very much, then, Carol, and thank you for inviting me to this event. I know I'm on, and a lot of other people from the unit are also on this call, because we can find it really, really fascinating and fantastic to hear these perspectives and all the really good chat down the side as well. So thank you very much. I am officially DWP, but I'm part of the joint work and health unit across DWP and DHSC, and that was formed in 2015 in recognition of the really hugely important link between work and health. We have a focus on government has tended to articulate its ambitions in the using the phrase disabled people rather than long-term sick, and it's been really interesting to see the LTS gap rather than the DEG, which is what we're used to looking at, the disability employment gap. But we've certainly been always had a focus on both disabled people and people with long-term health conditions, and that's only grown with this focus on growth. It's definitely feeling like the area we've been working for some time is being recognised very much publicly and across government in the importance of inactivity as a constraint on growth, and also because of the growing trends that Josh so brilliantly explained earlier. So in the spending review 21, which set the budgets for the next 3 years, of this year and the next 2, the government did look to build on a lot of the evidence. And again, Stephen talked about some of the things we've been doing and he's been working on. We've been doing a lot of tests and trials to really build up the evidence that we can draw on what works, and in terms of support for individuals to remain in and get back to work. We've had a big focus on moving upstream in that prevention space, so moving more into how do we keep people in work, stop them falling out in the first place, and as you said earlier, Dame Carol, the importance of being able to work alongside a health condition, and the effect, as someone said in the sidebar, the effect that by supporting people to stay in work, they can stay well, and so you have that really positive health and wealth outcomes. So we've got a three-pronged focus on the prevention, keeping people in work, keeping people healthier. So the creation of the Office for Health Improvement and Disparities is very focused on how do we improve the health of the population, and that has that really early stage prevention effect. But we've got a big focus on the supporting people not to fall out of work when they are unwell, and being able to work alongside their health condition to act quickly when people do fall out of work. As Josh highlighted, the unemployment rate is higher for long-term sick. So we know people are more likely to fall out of work with a health condition and then find it harder to get back. So real focus on earlier intervention, but also on those personalised interventions for those who've been out of work but are keen to work. So people have mentioned so many things already. We launched the Employment Advice in IAP rollout, or announced that rather, on Monday this week. We've also recently launched an information and advice service for employers, which we're now is on gov.uk, and that's in public beta, so able for anyone to access, and but still under development and improvement. And that is very much about tackling that point about employers needing to know what to do and how to do it. So lots of things, and I'm aware I'm completely out of time for my intro. So the only other thing I will mention is that, as Stephen said, the Secretary of State is speaking at the same time as this event, and really focused on that importance of engaging with employers and employers stepping up, but also being supported to know how to do the right thing. So that's a really, really key focus for us, and I'm delighted to be part of this discussion.
Can I just ask you, Jennifer, I mean, employers have always seemed to me to be a very important part of the work that DWP should be doing. Moving forward, any specific programs or projects with employers rather than just giving them guidance? Because we know that for a lot of companies, the guidance sits on the shelf.
Absolutely. And so the guidance, I think, is important, not because we want to put more on the shelf, but because one of the problems is that there's a lot of confusion and there are a lot of sources of guidance. So the purpose of that is to really put definitive, single and easily accessible source of guidance together. But we also have the Disability Confidence Scheme, which is really important, and we're really focused on trying to improve that and to help that be really ask more and support more for employers to move up the rankings, because it's got 3 stages, as you'll know. So you can sign up to, and you progress through, and we'd like to, and we are working to get more of that happening. We've obviously got a lot of work on the occupational health world and how we improve access to occupational health for small and medium-sized enterprises, and so self-employed, specifically where there's a particularly shortage. So and we are very much in the space of looking at what more we can do. We want to do the things we've identified, but also build more into that.
Thank you very much. Thank you. I think we will, any sign of Steve yet, Nick, or should we?
Yeah, Steve's here. Yeah, well done, Steve.
Oh, fantastic. Yeah. Steve will take you next. And I feel sure this will be with a occupational health direction.
It's apologies, my broadband keeps dropping out this afternoon. It's not the broadband, it's the Wi-Fi. So I'm connected to a very primitive router at the moment, and I don't know how long it's going to be good to me for. So I'm speaking from the Faculty of Occupational Medicine viewpoint, and there is very good evidence that good work is good for you. There is also good evidence that being workless has a worse prognosis than many common diseases, chronic kidney disease, ischemic heart disease, and many common cancers. So worklessness has a significant mortality and morbidity, and therefore a significant cost to the community in more than just benefits. And a significant part of the problem that we have at the moment is that less than 50% of the population have access to any kind of occupational health service. Only 20% of employers offer any kind of occupational health service, and less than 30% of the population have access to an accredited specialist in occupational medicine. And this was a choice that was made in 1948 by Bevan, that occupational health would not be part of the NHS. It should be the responsibility of employers. And I think the feeling was that people's health would improve very rapidly under the NHS and it wouldn't be required. And that's not entirely turned out to be the case. One of the things that the pandemic has highlighted is the lack of infrastructure in terms of occupational health, and the lack of bodies out there And that's appeared in terms of things like, for example, risk assessment for keeping people in work, telling people they need to isolate, getting people back into work during the pandemic, but also advice on planning return to work, phased return to work, and so on, which is what we do and which is what we do best. Now we're working very hard at trying to increase the workforce, and there are various things going on at the moment, including I'm talking to HE about creating some hybrid posts with 2 employers, a public sector, private sector employer, which kind of keeps the cost down to the Treasury. We're also expanding the number of doctors who are doing the CSER route, which is the alternative to becoming a consultant down the standard training route. And we also are launching in the next few weeks a new diploma aimed at allied health professionals, which is called the Diploma in Occupational Health Practice. So this is a modular diploma initially aimed at nurses. There's been a great deal of interest in it, and we're going to open it out to physios, OTs, and so on. Hopefully early next year. But it does a lot of things in that it benchmarks what an occupational health nurse should look like in terms of skill set. It creates a degree of career progression. And while this conversation hasn't been had, there is a conversation to be had with NMC about advanced practitioner status, which again creates more of a career pathway for occupational health nurses and gives them something to aim for. So there are various things in play, but the bottom line is that there are not enough specialist occupational physicians to cover the requirements of the UK. There are currently about 550 members and fellows of the faculty who are currently active, and that just is not going to work in terms of providing coverage. So the only model that can possibly work is a hub and spoke model based around accredited specialists, either in the public or the private sector. Or what we'd really like to see with the expansion of the new ICSs is public health is already embedded in the ICSs, and we'd like to see occupational health embedded there at strategic level, again with the hub and spoke model based around an accredited specialist with other allied healthcare workers, nurses, physios, OTs, counsellors, case managers delivering the service. And we have been working with Janelle de Gruchy at OHID with a view to trying to pilot some schemes like that with initially a service for GPs who have patients at high risk of falling out of work, falling into worklessness with that high morbidity, mortality and cost to the Treasury. And we're having active conversations about that at the moment. So there is a lot going on. I think the problem is well appreciated now, partly due to the pandemic and partly due to wider experience. And also, most recently, you will have seen the ONS report about the big increase in economically inactive households since 2019, with a bigger proportion of people workless due to ill health than there has been for 2 decades. So this is a big problem and a growing problem, and a very large part of the solution to this is occupational health and occupational health professionals. And we're there ready and willing if government is there ready to provide the resources and the infrastructure so that we can get on with sorting it out.
And Gisela, how can occupational health work more effectively with vocational rehabilitation? While you were having trouble with your IT, Steve talked to us very persuasively about the experts that we don't make use of, including OH, but, you know, disability specialists, vocational rehabilitation. They don't get the look in that somebody who's selling yoga and fresh fruit would get. And yet it really, they could be crucial in the workplace.
Yeah, there is a huge opportunity here. And one of the things, or two of the things that we do that most doctors don't, are functional assessment and identifying and breaking down barriers to work. So that's where the accredited specialists come into this. Now the other thing which for me is really exciting is, sorry, my parrot is kicking off in the background. If you can hear noise, that's the parrot. The other thing which is really exciting to me is the long COVID clinics, because these are one-stop shops for people with chronic illness. And long COVID presents like almost any chronic illness, whether it's ischemic heart disease, chronic kidney disease, with fatigue, loss of stamina, tiredness, shortness of breath, pain, and so on. And these are one-stop shops for addressing that. And this, I very firmly believe, is a model for the way forward of helping people with disability, chronic disease back into the workplace by having a one-stop shop that includes case managers, vocational rehab specialists, disability specialists, benefit specialists, or if all of these things were centralized in one place and accessible to anyone with a chronic disease, this would be a huge step forward.
Steve, thank you very much. You did mention general practice, so I wonder if we should come to Shruti and to talk to us about the work I think that you've been doing in general practice, because it seems it follows on quite nicely from what Steve has been saying.
Thank you, Carol. Just trying to, there you go. Thank you, Carol. So we are doing some work based in primary care with work coaches and disability employment advisors actually sitting in GP surgeries. And that's now going to be extended out to those practices where they have allied health professionals as first point of contact already sitting in primary care, where patients are referred to the disability employment advisors, work coaches for work-related support, but also for other support. So they can look at, as many of you in this call will know, that actually many, they can look at multifactorial issues. So whether that's financial, housing, other sorts of support that's required, as well as health and work support. And then we're extending that to a pilot of referral on to occupational health, where required, using a form of triage. And this will include whether it's a social prescriber, a link worker, an AHP, or a work coach or a disability employment advisor. And that's in recognition that actually these individuals are in many cases already sitting out there in primary care. And actually, I believe there's a good way of linking up this whole infrastructure and some key sort of pathways missing that we could actually link up. So that's I'm really excited. We've actually been running since the 1st of September. And we launched the occupational health arm of this project on the 1st of November. So thank you very much, Carol, for bringing me in there. And I'm really excited to be able to share that with colleagues on the call.
Thank you very much indeed. And of our speakers, I'm going to go finally to Ewan MacDonald. Ewan has vast experience over many years in this whole arena and comes to us from Glasgow, I think. Ewan, I think that you're going to probably talk to us about some of the health-related issues and from your own work, how they relate to worklessness.
Right, thank you very much. I have to say it's been a fantastic meeting. And
yeah, I can only see your head.
We can see the top of your head.
All right, that's because I'm not. That's because I'm looking at you and not admiring myself. So
that's better. That's much better.
Is that better? Okay.
Yeah.
Right. I don't know if looking at me is a good thing or a bad thing. Anyway, so well, a lot of the area has been. I'm coming at it from an occupational health perspective, and 47 years of working in this arena specifically before doing after doing other quite considerable medical training, and so the issues are very serious at the moment. I think one caveat I would say is a lot of the programs you've heard from Shruti and Steve Nimmo, and these interventions often are relating to NHS England. Scotland has got a different system, as has Wales, as has Northern Ireland. So I'm on for example, I'm in the long COVID task force in England. I'm on the long COVID committee for Scotland, and I'm on the Bevan Commission in Wales. So I know what's happening, and it's different in all the different places. So there is variation, and some of the initiatives have been talked about by the faculty and by others about Shruti and what's happening are all very positive, but it's not necessarily a reflection of what's happening elsewhere. What is the issue is the resources. And Steve has already talked about the resources. The UK probably has the lowest provision of occupational health advice to the working age population of any developed nation. And it's really quite a disgrace. And that's because it's never been made universal. It's not provided by the state, and employers essentially decide to hire it, and the specification of the service they ask for probably is based on the opinion of the HR director. So, so it can quite vary. But to go back to it, I'm trying not to repeat what everybody else says, so it's of some use. So I've been doing research in this area for a very long time, and the big problem we have, which is the same as every other country in the world, is an aging population. The majority, increasingly, it's very, and that's a global phenomenon. The other problem we have, which applies to healthcare services in general and occupational health in particular, is the lack of resource. Recently, the Royal College of Physicians said we needed another 50,000 doctors by 2030. There's not a hope in hell. It's all very well saying that sort of thing. We're not going to get them. We will maybe expand them, and I'm talking about medicine in general, but we actually have to change the paradigm of how we deliver support to working age people. Stephen's presentation talked about people think of workers as people who are employed, who are pensioned, who get a regular paycheck, and all that, because everyone at this meeting is in that scenario. So they often tend to think that's the world of work. Work is purposeful activity, and it can be a home worker, many carers, voluntary workers, third sector people, monks, nuns, all these other people are in the workforce, and people cycle from one area to another. It's really important that occupational health should not just be focused on the working age people. And what happens generally in the system in the UK is that the people who get occupational health it's inverse care law, whereby the best organisations will have good occupational health, and lots of organisations will have no occupational health. And the best organisations tend to have healthy workers. So the healthiest workers in the UK are in nuclear industry, for example. But many other workers working in less advantageous environments, believe it or not, actually will have adverse health. So there's a really big issue of inequity here, and the current provision is just widening inequalities, which is a major cross UK issue. So we're occupational health services, and I'm still practicing in occupational health. I still see patients as well as do research, is that we're dealing with older people with multimorbidity. And that's a routine challenge in occupational health. And the role of occupational health people really is to help people function. The health service focuses on treating a disease. Our OH services, which have to be very multidisciplinary and are better if they're multidisciplinary. So nurses, technicians, physicians, physiotherapists, AHPs are exceedingly valuable, and yes, case managers, biopsychosocial rehabilitation case managers are increasingly being employed. But the provision of it is very unequal. These are fundamental things I object to in the UK because we're just exacerbating inequality. Now, what's happening is not new, though. Everyone's talking about the sudden rise of middle-aged workers and falling out of work through ill health. In 2014, ONS reported that 50% of the UK workforce leave employment between the ages of 50 and 64 years. Interestingly, the self-employed have a much more natural functional curve, and they survive proportionally longer. So a lot of people will leave the workforce and have been for a very long time. Now, this coincides, if you look at the charts on multimorbidity, this coincides with the growth in multimorbidity. So probably you're a reasonably mature group, you all look exceedingly handsome and young, but probably 33% of people participating today have at least one morbidity, and some of you will have two, and some of you will have three. And it gets more as you get older. So it's not a matter of if you're going to develop a chronic health problem, it's a matter of when you're going to develop a medical health problem. Now, the big issue for the worker that's got a health problem, and we're all going to get health problems, so let's consider any worker, whether in an organisation with a health service or not. But let's consider somebody who's not got an occupational health service. They get a health problem, they get another health problem. They're perhaps working for a SME, there may be 20 people. The one manager has to do all the things himself. Suddenly employee gets a couple of things and struggling at work, starting to have sickness absence. What do they do? Well, the issue is healthcare does not help. The NHS does not help at all, because the NHS doesn't deal with multimorbidity, it deals with disease models. So if you've got a chest problem, you go and see a respiratory physician. Cardio, it's a cardiologist. Neuro, it's a neurologist. And actually, in the world of work, we've got lots of people with multimorbidity, and multimorbidity is the key thing which predicts falling out of work. We've just done and the problem with going to see a uni specialist, going to a uni specialist clinic, and this is a problem that's been for long COVID, which is being addressed very well in England, not so well in Scotland or Wales or Ireland, is that a one-stop shop where actually people take a holistic view. Now you might say, well, the GPs do that. Yes, but the GPs are very hard pressed. They've got 7 to 10 minutes, and they now in their work focus on the issue that you have when you walk in the door. And they're not they can't be very receptive to the just one other question, doctor, as you're heading out the door, because their time pressures are so intense. So they're very holistic, and they understand the psychosocial factors of health, but they don't have time to do it. So the only people who are clinical insights are people who are working in occupational health, and I've told you where they're working. They're looking after the big blue chip companies, all of the public sector that are very well represented here, but out there in the the diaspora, there's much less of it, and what is being provided is not acceptable. We've done recent research looking at over 13,600 people going through the welfare to work program, and looked at the over 50s. And it's very clear there's a startling relationship between the number of medical conditions they self-declare and their likelihood of losing their job, and also the likelihood of ever getting back to work. So if you've got if you lose your job through ill health, and then you go through a workplace and a government intervention, which are variable effectiveness, you've got a 60% chance of getting back to work if you're an over 50 worker. If you've got 5 medical conditions and you're an older worker, and that's not unusual, we're talking about serious problems, we're talking about just different system problems. 5 medical conditions, the likelihood after a workplace an out-of-work intervention provided by government is you get 6.4% going back to work. And the issue is we have these programs for people who are falling out of work, but we're not doing anything to prevent people, to help people as a country cope with the issues that they've got in work. And so our experience, and all the occupational physicians here have got wonderful war stories in terms of, I think the worst case I had was, I've had my long history as a programmer, a computer programmer who dived into a swimming pool which had no water and got a high cervical fracture. And actually he could move a finger in each hand, and we got him back to work with support, living independent support. And it's actually now even more possible with largely IT type work that people are doing, desk-based work, to help people get back to work. But often fear is the problem when people have got, fear is the problem for people have got 2 or 3 medical conditions and feel they're going downhill, and no one's talked about vocational rehabilitation, no one's told them how to improve their function. No one's told them that their muscles are reducing power by 1% per year from the age of 30, and you need to do something about that. They just don't know. And if they're not getting that kind of advice in any part of the NHS, then they become depressed and tough of their problems, and they fall out of work, and the employer doesn't know what adaptations to make. Is scared of the situation in case their work is damaging them and they don't have competent advice.
You're in 2 more minutes.
Yep, sure. So I'm just giving you an idea of the reality out there, because we've talked a lot in this meeting about the ideal, really. So there's a big issue about how workers are dealt with by treatment health services, which are all overloaded and very stressed. And they're dealing with people in a siloed way rather than a holistic way. So what can we do about it? Well, first of all, an approach for anything has to be about prevention and giving people proactive advice about work and occupation. And we should have universal access to occupational health for all of working age. Also, we now can predict, there's enough evidence, I can predict who's going to fall out of work, because there's been enough published, but it's not really been put together and no one's applied it. We need to start doing screening and identifying people at risk so they get good vocational rehabilitation, good biopsychosocial condition management, just as Stephen was saying. That's the right way forward, because it's not about what's wrong with you, it's how you handle it and what adjustments are made with the workplace. So I'll stop there, bit of a rant, but I just tried to cover some of the real reality out there, and we do need. This problem is not going to go away unless we actually start to focus on providing appropriate advice to the working age population.
Ewan, thank you. And thank you for sort of bringing us back to reality. Nick, what I'd like to do is take any questions that there are out there, either in the chat, or if there are any hands up. If you wish to ask a question, do put up your metaphorical hands, so to speak. And Stephen will be available on the panel should there be any questions that need to be addressed to him. So Nick.
Yeah, I mean, the questions, there's a good comment from Steve Foreman from Health and Safety Executive about the work they're doing in terms of disabled people and helping those back to work. And I mean, I suppose from the side of occupational medicine perspective, you know, we're right behind the government and DWP in terms of its health as everyone's business consultation response and everything you said, Jennifer, but clearly, you know, our ambitions need to be higher. You can hear the comments, the work that Stephen's doing to kind of get a commission and a kind of sort of employment service. So I suppose it's that level of ambition, and you know, we hear there is maybe some unspent money, although clearly the politics of that might be difficult in terms of accessing it. And it's just from what was clearly we're an outlier in terms of other countries in terms of activity. You know, what is the government, I mean, just doubling down your question, Carol, in terms of what is the government actually doing to put services on the ground, not just guidance? I mean, obviously there's that announcement in terms of IAPT and employment advisors, but you know, you can see the ambition that we've got to grow the OH workforce, multi-stream workforce, the opportunities in primary care, and I suppose, you know, throwing it back to the DWP is like, we're here to help, we're offering some solutions. And to what extent? I mean, I suppose it's a slightly tricky time with Chloe Smith speaking at this moment, but it's her ambition, isn't it, as Secretary of State, to push on this. She understands the issue, so it's really kind of putting pressure a bit on you, Jennifer, to you know, take this away, obviously, and there's people from the unit on this call, but to, you know, we want to see those concrete actions at pace being delivered.
Jennifer, do you want to come back at all on what Nick has just said?
Thanks, Nick. Yeah, absolutely.
You come on mute. Go for it.
Sorry.
Yeah, I can hear you.
Am I back yet? I think that's the.
Yeah.
Sorry about that. I think I would have been better doing this at home. I'm in the office where the Wi-Fi is not excellent. Yes, so thank you. Thanks. But yeah, seriously, we're very ambitious also. I think we were in a place when we published the Health is Everyone's Business consultation. We definitely think those are good things to be doing, absolutely right ways to be approaching this. But as you'll also know, Nick and others, we've been working very closely, the policy teams have been working very closely in partnership with your organisation and others. So we've had the working group on workforce. So we are deeply open to the thoughts, but I think one of the things I certainly afterwards thought I should have said, emphasised more, is that yes, there is, government can go so far. I mean, you'll expect me to say this, government can go so far, but we can't do this alone, and it's so that offer of being there and with the ideas, with the support. So very much see this as partnership with other organisations outside government. We're very keen to be delivering. So yes, we as you say, we've announced employment advice in IAPT. We've also extended the Working Health Programme. We've expanded IPES, the individual intensive personalised employment support. That so those are DWP contracted employment support programmes. We're also expanding our offer of work coach support to individuals who are on the health journey. So that means they basically have had a fit note and are either on their way to having a work capability assessment or have had one and have been on the books for some time, but left alone, completely alone without that support. And we are also bringing forward a white paper this year, looking more at how the benefit system can better incentivise and de-risk work. So there's lots of activity, and one of the things that's always a challenge is, I think it's right, there's lots of activity, lots of different activities, people trying to tackle lots of different things, people with different conditions, different social environments. So we have a bit of a large scale programme. We have a lot of things we're doing. Some of them, obviously nothing happens as fast as we'd all want it to, but we are progressing at pace, but we are absolutely aware of the need to go further and to look at raising the ambition. Social State Working Pensions, as you say, she was the Minister for Disabled People, and in that role she was very ambitious and very focused on work and health and where we could go further. And she is very keen to be asking more of employers. So alongside the work we are doing, we're definitely in the market for building up on that.
Jennifer, there was in the chat, I think earlier on, a question about SMEs. So can we just get you to perhaps say a few words about, because when you were doing the work sort of 2 or 3 years ago, it was very much recognised that SMEs really don't get any of the goodies. They get no OH, they've really often not got HR. It's a pretty bleak place for them in terms of support to do the right thing.
Yes, absolutely, and we're very, very conscious of the SMEs and the self-employed as well being underserved in this space, as Ewan was also saying. That's where occupational health support does tend to be focused. So all of what we're doing is focused and targeted towards improving access where it is needed, which is obviously at that end, at the smaller end, and also at the lower qualified, lower skilled end of the labour market. We are looking at market navigation support, so to help employers to know what they're buying, and also we'll be testing a financial incentive. The workforce work I've mentioned, which is in partnership with someone from, is very much about how do we improve the access with that targeted end for SMEs. And then all of the information and advice, as mentioned in the HSE guidance as well, is very much about filling that gap as much as we can for those organisations that don't have the expert advice that's just in-house. They haven't got the HR director, they haven't got the so they need that really straightforward, this is what you need to do, this is how to get to it, this is how to do it quickly at the right time. So we do think that's a really fundamental underpinning to the support for SMEs, but again, it's an area of focus.
Thank you very much. Nick, any other questions or comments that we should pull out?
I don't think so. I suppose at this stage, it'd be good to get a kind of summary from you, Carol, and then a close from Shriti and maybe others like you and Steve in terms of next steps. I mean, we're very pleased obviously to have this kind of data overview and analysis, and now we need the kind of wraparound delivery. And I suppose also looking at what other countries have done. Finland have that occupational health for people leaving hospital to keep people of working age quickly back to work so they don't drop out of work. So keeping that innovation and dialogue going, we want that with DWP, and we hope delivery will be more comprehensive, because clearly all these things is not enough in terms of the where we are in the UK. Josh's kind of graph, which I've sort of tweeted out, which is all other sort of advanced economies are over here and we're over here, so something bad is going wrong, and everything that we're trying to do, I'm sure is helping, but we have to move the dial further. And it's not necessarily about sort of kind of punitive approach to welfare. This is about supporting people with the health conditions and of particular professions, and that drill in on occupation I think was really interesting to help those people return to work. Yeah, I mean, I did put in the chat if anyone wants to raise their hand or come off mute. I mean, there's obviously people like Paul Litchfield and others who've got a lot to say. Kim Burton, from the biopsychosocial approach, I think is obviously key message. So I don't know whether we should just open it
Kim,
out.
any final thoughts from you? Any, you don't have to, but if you had anything you wanted to throw into the mix.
So if that was directed at me, Carol, so the only thing I would comment on is I think stimulating the supply side in occupational health is absolutely necessary. It's been necessary for decades, and it's good to hear what Steve and Nick and others are doing in that regard. But we've got to think about the demand side too. It's all very well saying all the time, oh, SMEs need more of this, but SMEs have got to want it. And there isn't a lot of evidence that SMEs are actually jumping up and down saying we need more occupational health. And that's where I think we fall down too often as a profession, and indeed in the public sector for government. We don't recognise that demand side. And one of the things we're trying to do in the Midlands at the moment with the Midlands Mental Health and Productivity Pilot, which is part of the Midlands Engine, is to get out there and really engage with SMEs and talk to them and those who represent them through chambers of commerce and whatever, to actually explain what advantages this can give them, how it can help them with real problems. And I think we just need to do more of that. Otherwise, we'll simply create a workforce that will end up serving the organisations that need it least. And it'll be a bit like access to work, where an awful lot of the people utilising access to work were actually in the public sector. And we could well end up in that situation too. So let's think about the demand side as well as the supply side.
Thank you. Kim, anything from you?
Yeah, just briefly, I suppose. We've talked quite a lot about delivery of services and who's going to deliver them. But there's also the other flip side of this, and that is what is being delivered. And I'm not altogether sure that all the various different service delivery mechanisms and people are delivering just the right stuff to the right people at the right time. And I'm not going to labour this point, but I'd like to just mention what we've been playing at for the last couple of years is trying to develop a protocol for a return to work plan, a biopsychosocial instrument that engages the person. This is the other expert that perhaps Steve didn't mention earlier on, and that's the worker themselves. They're often the expert in knowing what they particularly want and trying to harness what their obstacles are to returning to work or staying in work for that matter, and looking for solutions that the workplace can offer, whether it be work modifications or whether it be to help with other aspects of life, and putting that into a plan that's agreed between the person, or the worker if you like, and the employer and the health professional, so that all players are on side and kicking the ball in the same direction. Getting a consistent protocol for that seems to me to be quite an important thing. And okay, it's a work in progress, but we'll come back and tell you about it perhaps. Well, thank you. So just thank you, Carol, for letting me have my
No,
little
I
moment.
mean, there are so many ideas. I mean, I suppose the future we really want to be aiming for is to enable as many people as possible, whether they be in work and at risk of falling out, which is a group that has been recognized, that we have these people who are perhaps teetering on the brink and could be adding to our list of people who are workless, whether they're that type of person or whether they're the people who are economically inactive but would wish to move towards the world of work. And I think that can be really quite frightening. And although it doesn't sound very scientific, I do think that something strange happened in the pandemic. We've always had people with long-term conditions and disability who we've been wanting desperately to help them stay in or get into the workplace. We were getting a bit better at that. But what I still don't understand, what has happened in this last 2.5 years that has made some of those people feel the workplace now is no longer for them? Have they become deconditioned? Is it fear of going back? Is it a reevaluation of your life as to this is no longer where we want to be? I think there's quite a lot to understand in this economically inactive group, and perhaps some of the methodology we've used before to help them. And just back to Steve's point about, have we got the right experts at the right place? And to your point, Kim, are we really listening, personalizing it to the people we want to help, so that for the future, we can enable as many people as possible to be in a good place and feel that work gives them something valuable, gives them something which is good to have, rather than something I think I could really easily give up or escape from. And I think we made it quite clear we certainly want government to play its very full part, and government working with employers. But again, for employers to really understand the issues, and perhaps particularly to think about the groups 50 to 65, where we have indeed lost more. It saddens me enormously listening to what Steve had to say, the number of people who have been made to wait for surgery that would have enabled them to be in the workplace, or for medical care that's now made it almost impossible in their own minds for them to be in the workplace. Now, that is something, it would be wonderful to be able to do something about that, because it is an element. There comes a point, says she who's had a knee replacement, when pain becomes the major issue, and you can't really easily cope with it. So I think it's been a very rich discussion. The problem is pretty stark. I think we've had a lot of potential solutions. No one size will certainly not fit all, and it would be really, I think this is an ongoing a discussion, Nick, and I hope that you're not going to let go of this topic, but that we will follow up on many of the things that we've heard, and really see whether in fact we are getting to grips with this problem. We really, really do not want it to be worse. I think, and I'm very sad to say this, that it's worse than when I started doing the work for my first review. It's worse than what it was like when I started on working for A Healthier Tomorrow. And that gives me no pleasure whatsoever to say that. So there's a great deal to do. So I'm going to stop there. I think we're now into the closing minutes, Nick.
Thanks, Carol. Yes, I mean, there's a useful comment from Ira, and sort of building on what you just said in terms of understanding what are the drivers for the data, and what is happening. And the last 2-3 years have definitely gone backwards. So we shouldn't just leave today about more research is needed. More research is needed, but also it's about working with Jennifer and her team, Amy and Eden's working Health Unit, to provide that personalised care. But I'm going to thank you, Carol, and hand over to Shriti Patani, President of SOM, to wrap up the day's proceedings. Thanks, Shriti.
Thank you, Nick. So excellent afternoon. Thank you to our presenters and our chair, Carol, and also for those of you who've attended, excellent discussion. Clearly a lot of passion within this group. The data has driven that passion further. Call for action from all angles, from government, but also from those of us working more on the front line. And I'd just like to sort of give a shout out, I suppose, to the NHS for their growing occupational health and wellbeing together programme, which is about to launch its 5-year strategy on developing occupational health services across the NHS, and hopefully extending further out to primary care and to social care in due time. And I know Steve mentioned, Steve Nemo mentioned working across ICSs, and the potential there of then extending that out further to GPs and their patients. We've also heard from Paul Litchfield this afternoon about the work that they're doing out with the SMEs, and certainly as a jobbing OHP who has provided services to SMEs, I often find that SMEs don't always know what is out there and what support can be provided. So it's great that we're coming at this from very many different angles, and also good to hear about some of the potential solutions, and bearing in mind that we need to look at, are they being delivered at the right time, and are they the right solutions? But great discussion, lots of thought-provoking comments, and again, a big thank you to all of you who've been here this afternoon, and let's continue with these discussions and move forward with the ideas. So thank you again very much.
Thank you very much, Susie. Right, Nick, I think that is it, and we can release everyone.
We certainly can. Thanks very much, all. Do stay in touch. Really useful session. And Josh, I've asked you by email, but it'd be great if we could share your slides with others too. And thanks for your responses on the chat.